Okay, and welcome. This is going to be the first lecture of the course, and this is the Introduction to Anatomy. So you're going to notice that a lot of this information is not going to be required to know for exam one. Okay? You've got study guides for each exam block. And what I've done for the study guide is I've just pulled out the most important information that I'm going to test you on. And this information isn't going to be maybe as straightforward as you're used to in your lower level science courses, what we would call just memorize and regurgitate. It's more applicable. So we'll use case studies, and there's different ways that we can format those questions to truly see and if you understand the material and test your knowledge. But the reason that a lot of the Introduction to Anatomy lecture, you don't really need to, I should say, it's not that you don't need to know it, but you're not going to be held responsible for it for the first exam, is that a lot of this should be a review to you. I would say probably 90% of this should be a review from Bio 1, and if you've taken Bio 2 as well. And so it's just expected that you already know this. We're just doing a review just as a reminder for this Introduction to Anatomy lecture. But as you should already know it, you should already have this foundation of knowledge laid down. I really shouldn't need to test you on it. So a couple things you'll notice from this first lecture is going to be covered, or that you'll need to be held accountable for knowing in great detail for the first exam, but not all of it. Doesn't mean that the material isn't any less important if you don't need to be held accountable for it for the exam. But again, this is stuff that you should already be familiar with. So with anatomy, there's several ways that we can study anatomy. Okay? Really, when we're talking about anatomy, it's all form, it's all structures, right? Whereas it's kind of similar field of study in regard to the human body. Physiology is all about function. So we say form and function, anatomy and physiology. So there's certainly several ways that we can look at anatomy. We can look at anatomy from a gross standpoint. So that's looking at anatomy and those anatomical structures in a view that's going to be bigger than 0.1 millimeters. So as seen in dissection, we can look at smaller structures on the cellular and tissue level. And we can use microscopy to be able to look at those details. And this is histology. We can take anatomy and we can break it up and we can look at it from a systemic standpoint. So investigating or studying one system at a time. And certainly there will be points during this class where we'll look at individual systems within an exam block, but we look at it in a different way, and that's regionally. So we'll start off with the first lecture series, and that's going to be after the introduction, the head and neck. Then we'll move into the thoracic cavity and all of the important structures in there, then the abdomen and the pelvic cavities, the upper limb, and finally in block 5, the lower limb. We can also use a combination of investigating what's on the inside and then how do we see that on the outside. And this is surface anatomy. Surface anatomy is what you're going to be utilizing in a clinical setting with your patients. So you're not going to be able to see what's on the inside. They're going to be telling you, right? You're going to be asking questions about symptoms. Does it hurt here? I have swelling or discoloration in this area. I've lost functionality in this part of my limb. And so then we're going to take what we know about gross anatomy, histology, how we've studied it regionally and or systemically, and apply that to what we can see or palpate, which is feel, on the outside, and that's surface anatomy. So certainly most anatomy courses will start at the tissue level, and that's really where we'll start as well. We talk about tissue, organs, organ systems, and then how that relates to the organism itself. Biology then would have started at the chemical level. So starting with atoms and talking about how those atoms then are bound together, and atoms, when they come together, either atoms from the same chemical or atoms from different chemicals can come together and form molecules. And then putting molecules together, then we can have cells formed, and that would be cellular biology. And that's usually where basic biology, Bio 1, leaves off. Bio 2 then, if you've had it, it's not a requirement or a prerequisite, Bio 1 is, but Bio 2 is not a prerequisite for this course, although it is recommended because it just gives you a better foundation, but not required. Picks it up at the tissue level and moves forward. So that's really where we'll start a lot of our conversations. So just some basic things to be reminded of when we talk about the location of anatomical structures. We are always going to take it for granted that we are starting with an individual who's in the anatomically correct position, unless we're stating that they're lying down or they're in a different position or a different orientation. We're always going to say or just assume that how we discuss the location of our structures within our bodies is having an individual in the anatomically correct position. So that's standing, facing forward with the palms forward as well, just like this individual here. Once we have established that, then we can take different planes, and we've got diagnostics to do this. An MRI, for example, can show these transverse sections, and I'll show you what I mean by that in just a moment. So we can then look at the body via mid-sagittal plane, frontal plane, or a transverse plane to get a better idea of what's happening on the inside. We've also have a common knowledge, a common terminology that we use, almost like a common language that we use to be able to communicate with our colleagues in regards to where we are finding the location of structures within a body. So you're going to go over this in lab on our YouTube channel that's specifically for our lab videos. The first video up is all about terminology, and that's something that we encourage you. I think it's actually required that you watch for lab. So this is just going to help you. This terminology is going to be super important. Not only are you going to be held accountable for knowing it in lab and certain terms in lecture, but we're going to be utilizing this in part of our discussions. And then also it's going to be utilized in test questions later on, just describing, part of the questioning, setting up the question itself is just describing where something is located. So you'll need to be familiar with these terms. So these are just a few of the terms that we have. So take a look at that. Probably the most commonly used are going to be proximal and distal, and these are only utilized in the upper limb and the lower limb. If something is proximal, it is closer to the attachment point. So for the upper limb, it's going to be the shoulder. In the lower limb, it's going to be the hip. If something is considered distal, it's further away from the attachment point. Now, in order for that to make sense, we need to be comparing our structure of interest to a neighboring structure. So what do I mean by that? If I'm trying to describe where the elbow is in location to the entire upper limb, okay, I can say that the elbow is distal to the shoulder, right? The shoulder is the attachment point. The elbow is further away from that. So the elbow is distal because it's further away from the attachment point, distal to the shoulder. However, if I'm relating that to the wrist, I would say that the elbow is proximal to the wrist, because now in this scenario, the elbow is, out of those two regions, closest to the attachment point. So just because a structure, for example, the elbow, is distal in one scenario, doesn't mean it's going to be distal always, because in the other scenario, it's going to be proximal. So those are two terms that you have to be familiar with. Superior and inferior are easier. Superior is when we're comparing two terms, it's going to be the highest most point, inferior the lowest. Anterior and posterior, then anterior is toward the front, posterior is toward the back. Medial and lateral, if we draw a point right down the middle. This is the midline. Any structure that's falling closer to the midline is medial. Any structure further away from the midline is lateral. And then superficial and deep. If I can touch it, it's superficial. If it's underneath the surface, it's deep. Okay. So please be familiar with those terms. And this is also just showing us a visual of those terms. Okay. And this is coming from your book, Table 1.1. We're going to see that we discuss cavities in the body. And so we have, depending on the textbook that you read, either 3 or 4. So what does that mean? So we have the cranium, certainly. We have the thoracic cavity. Thoracic cavity is a separate cavity because we have this nice flat muscle called the thoracic diaphragm that's separating it from the cavity that is inferior to it, and it's the abdominal cavity. Some textbooks will have the abdominal cavity and the pelvic cavities separate. Some textbooks choose to put them together and call them the abdominopelvic cavity. Okay, our textbook will keep it separate. Interesting thing about our cavities is that they have their own unique associated membranes. Okay, so we have a modified membrane in the skull that's helping protect the brain. We'll talk all about that in the head and neck lecture. In the other cavities, we have this very unique, what's called a serous membrane. So a serous membrane is a sheet-like tissue. Serous membranes secrete fluid, and specifically these serous membranes have 2 layers. One layer can either line the cavity, or it can form a sac-like structure around individual organs within the cavity. So we always refer to that as the parietal layer of the serous membrane. Then the other layer is going to be on top of the actual organs themselves. Okay, think of it like shrink wrap on top of these organs. And so this layer is referred to as the visceral layer of the serous membranes. Now we're going to give them specialized names when we get further into these blocks. So to give you an example, the serous membranes surrounding the lungs are going to be the pleura. Surrounding the heart is the pericardium. Surrounding the abdominal cavity is the peritoneum. So just a to be continued. I know that you've heard those terms before, but just to kind of giving you an idea. Clinical anatomy, we use a lot of that in this field. Most of you are pre-healthcare professional students, and you are spending time either scribing or shadowing, doing your clinical internships. And so we need to be able to make that relatable. So we need to be able to take this material and really show how it's applicable to what you're doing now and what you hope to do in the future. And so this is an anatomy course that's clinically based. If you take the graduate level anatomy course that I also teach, it is referred to as clinical anatomy. So it is all clinical information all the time. But this is just helping us then get a better understanding of it. How is it what we're learning? How does that apply truly in the medical field? Okay. So this is certainly its own field of anatomy. We use it in medicine. And so without subjecting patients to exploratory surgery, it is taking what we know and applying it. It's using that clinical or that surface anatomy. Okay, being good anatomy students, we learn what's deep and on the inside. So then we can apply that knowledge using surface anatomy and then also diagnostic techniques. Excuse me. You'll hear me say many, many times, know the clinical significance of a specific disease or disorder. Clinical significance just simply means what is the most important information for me in a clinical setting that can help me with the diagnosis and or treatment of this patient. Meaning if I had 2 patients in front of me, one had the disorder and one didn't. What are those unique symptoms or characteristics that can either help me? So what can I look for, right? what sets that patient apart from the normal or healthy patient that does not have that disease or disorder, okay? What are some unique symptoms? What is something that I can recognize as a deviation from the normal? And that's clinical significance. Excuse me. So what are some of these diagnostic methods or techniques then? So your book goes into greater detail. Now understand that there are required readings in your textbook. So for this first chapter, because we cover a lot of stuff, and it's just simply because it's a review, there are different pages coming from different chapters in the book. And I certainly wouldn't hold you accountable of just being able to find them, right? So if you go to the Start Here module, if you come down to Lecture Exam 1, when you find this PowerPoint, come right below it. And there's a Word document or an actual page in there that says something to the extent of page numbers for the Introduction to Anatomy lecture. There's a whole page that's associated with what we're covering here in this lecture to readings from your textbook. And so just to remind you, this is the book that we will use. You can certainly get a hard copy, but if you go to our course homepage and web courses, if you look over to the right side in the menu, one of those menu options says course materials. If you select that during the first week of the semester, you can buy that course material. It's an ebook and you can buy it for a significantly reduced price. I think it's under $40 and you can get that access to it immediately. Okay. If you choose not to do that, and I should say that that'll be pulled, that money will come right from your financial aid. If you choose not to do that, that's fine. You can also get our textbook, either an ebook via Amazon, or I think you have the option of buying an ebook or a hard copy also at our bookstore on campus. And that information is in the syllabus as well. After we get through the Introduction to Anatomy, those page numbers for your required readings are going to be on your course schedule. So if you go to the Start Here module, come down to where it says course schedule, open that up. If you look underneath where it says lecture material, you're going to see those associated page numbers. That's where the readings are. And remember, the homework that comes from the textbook. Okay, so make sure you're doing those readings. So to get back to this material then, our diagnostic methods that we can use, certainly X-ray, myelography. So this is where we can inject a medium or dye, for example, into the subarachnoid space. And if that doesn't make sense for you now, it will in block 2. And so anything we see MYELO is referring to the myelinated axons of certain neurons. And so this dye is being attracted to that. A barium swallow. This is going to allow for this barium sulfate contrast or solution to bind to or stick to the epithelial cells that are lining the gastrointestinal tract. So this is a barium swallow, but we can also use a barium enema on the other end. And what that does is it coats that epithelial lining of this tube, and it allows for me to be able to see it. So if I had any lesions, any constrictions, scar tissue, ulcerations, diverticula, which are little pouches that can form in there, I can be able to see that. Now, certainly we also have things like a CT scan, and this is just kind of going over how this is different. So why I would use this on certain parts of the body. I can enhance the contrast between tissues due to different blood flow by injecting this IV contrast. It does contain iodine though, and if you've ever had it, it's a bit uncomfortable. Some people get secondary symptom or get a headache as a secondary symptom from this, and then also just kind of sometimes an upset stomach. But again, it just depends on why we would choose to use this over something like an MRI. So an MRI, again, it just allows us to have a better idea of what's going on the inside. We don't need to use any kind of injecting of this contrast dye just because we're using a different type of technology. And then we also have a PET scan. This is allowing us to see messages, both, or I should say chemically, physiologically, and pharmacologically in the body. So it actually allows me to see processes as they're occurring. So again, not just a still picture, but how something is actually happening in real time in the body. So again, whatever I need, for example, this would be great for identifying fast changes in brain activity. I can utilize this different type of technology. And technology, it is increasing leaps and bounds. We also have sonography. So this is utilizing ultrasound techniques. We use this a lot in regards to maybe looking at blood flow. So we can do an ultrasound of the heart, looking for valvular competence, so how well a heart valve is working. We can also utilize this, for example, for pregnancy diagnosis in women's reproductive health, or pregnancy monitoring, other reasons throughout women's reproductive health, just to give us some examples. So then tissues, just to remind us, there are 4 tissue types in the body. Every one of the tubes in our body, so pick a tube, any tube, the gastrointestinal tract, blood vessels, the urinary tract, the reproductive tract, right? If there is a tube in the body, inside that tube, that open space is called a lumen, and that lumen will be lined with epithelial cells. Epithelial cells also cover our skin, so it is the top layers of our integumentary system. So epithelial cells cover, okay, or line. And there are several types of epithelial cells depending on their thickness and depending on, where they're located, right? Form follows function. And I'll show you what I mean in just a moment. Connective tissue supports. So what's some types of connective tissue? So connective tissue would be adipose or fat. It would be connective tissues like tendons and ligaments, aponeuroses, which are flat sheet-like tendons, retinacula, which are flat sheet-like. Sheet-like is then like, sheet-like. Retinacula, which are flattened, almost sheet-like ligaments. And we'll talk more about those in block 4. We also have bone, which is a type of connective tissue, and blood. Lymph is a type of connective tissue. So it supports and connects one part of the body to another. Muscle. We have 3 types of muscle tissue that we'll talk about. In block 2, we'll talk about cardiac muscle. Blocks 1 through 5, we'll talk about skeletal muscle. And then throughout, we'll also talk about smooth muscle. And then last, but certainly not least, nervous tissue. So this is more control. So we have 2 types of cells that we'll discuss in regards to nervous tissue. It is the main players, which are the neurons, and their helper cells, the neuroglial cells. So in regards to epithelial cells, these are found, again, covering the body or lining tubes, and form follows function. So in areas where we have a lot of friction, we will see multiple layers of epithelial cells. In areas where we don't have a lot of friction, but where what's more important is maybe transporting molecules either from the blood to the inside of this tube or from the inside of this tube into the blood, for example, during absorption after digestion occurs, we're going to see a simple layer. So when we have a simple layer, it's just simple. When we have multiple layers, we call that stratified. Now we have different shapes as well. We can have cuboidal. We can have columnar. And the smallest is squamous. Squamous just means squished. We can have cells that are considered to be transitional. Transitional usually means that they change shape when, for example, fluid is passing through them and then they go back to their normal shape when the fluid is done passing through them. We see this in the urinary tract. Some are going to look like they've got multiple layers when they don't. They're just very tightly compacted in there, and that's called pseudostratified. Some are going to have these hair-like appendages on the end, and these are called cilia, and this is to help with movement. And some have these finger-like projections called villi, that's not shown here. And sometimes they have these tiny little finger-like projections called microvilli, and we'll point those out when we're getting into each. And this is just showing us where we would find different types, and we'll point those out again as we're moving through the human body. Connective tissues then, well, they're found throughout the body. Interesting thing, what makes an organ? How do we define certain tissues, or how do we define an organ? An organ is made up of 3 or more of our tissue types. So our organs are going to have mostly, right, neural tissue, connective tissue, muscle, or epithelial cells. Most of our organs are going to have all 4, but by definition, they just need 3 of the 4. So here's our types of connective tissues. We did leave one off, cartilage. So just be familiar with these. We're going to talk about these throughout. One in particular that we spend a deal of time on in anatomy is going to be the skeletal system. So again, we don't talk about this as a system as a whole collectively. At one point in time, I know probably in undergraduate, or excuse me, in elementary school, middle school, or high school, you may have had to know all the bones of the body. Again, we're studying regionally, so you won't have to know that. But when it comes to the skeletal system, it's super important. It provides a framework along with the skeletal muscles. It helps facilitate movement. It gives protection to the underlying organs. So for example, in the thoracic cavity, our ribs, our sternum, and our vertebral column are going to help protect those very vulnerable and fragile lungs and heart. In the cranium, this is bone that's protecting the brain. This is also an area for mineral storage, and we're going to talk about that next. So after we talk about, what constitutes a bone and what makes up a bone, we'll talk about that mineral storage. This is an area where we store calcium. And so throughout the day, we need calcium. Calcium is super important for neural transmissions. So a neuron talking to another neuron, a neuron talking to a muscle and telling it move, or a neuron talking to a gland and telling it to produce something. Or for muscle contractions, okay? Calcium is what is driving muscle contractions, and so it's super important. When I have too much of it, I store it in the bone. When I need it in the body, I break some of that bone down, release the calcium in the blood, and get it to where it needs to be. In our bone is where we'll see the creation of new red blood cells and white blood cells. And then also energy metabolism, so bone building. So we start off during embryonic development with our embryonic stem cells, and these can be referred to as mesenchymal or mesenchyme stem cells. So these are kind of omnipotent, right? They're pluripotent. They can be anything they want to be at this point. Then they start to go through this differentiation process. So if you are going through a differentiation process, this means that you become more specialized. And so from those MSCs, we start off with cells that are more specialized, that become committed to certain formations. Okay, formation pathways, we should say. So anything osteo, osteo, anytime you see that, it means bone. Okay, Genesis means creation. So these are osteogenic stem cells, they create bone. Anytime you see chondro, chondro, chondra, that is cartilage. MYO is muscle, and then of course marrow, tendons and ligaments, and then anything adipo is going to be fat. So once we go through that initial proliferation and differentiation process, these cells are committed. Okay, and so this is the progressive lineage then for bone, cartilage, muscle, and so forth and so on. In regards to bone, we have three main cells that are coming from that specific lineage. We have our osteogenic stem cells. They go through another differentiation process and they become immature cells called osteoblasts. Now, anytime you see that suffix blast, doesn't matter where you're at in the human body, doesn't matter what tissue you're talking about, a blast is an immature cell. So in this case, our osteoblasts are immature bone cells, and their job is to actually produce bone. Now, you'll see this also referred to as bone matrix. It's just generically what we refer to as bone, okay? So what these osteoblasts do is they're able to collect things like calcium and other minerals, both organic and inorganic molecules, out of the blood, and they start to make bone. Now, these osteogenic stem cells differentiate into osteoblasts, and these osteoblasts are very close to their neighbors. And then they realize, I'm a bit more introverted than this. So they start to produce bone around them. Okay. And the more bone them and their neighbors produce, the further they are away from their neighbors. And they also get further and further away from their main vascular point. Okay. So where the blood is coming into this tissue. They reach a point where they're far enough away from their neighbors and they're far enough away from all these other structures that they then mature into osteocytes. So CYTES is a mature cell. Osteocytes can't produce bone. They can only maintain it. Okay, so their job, they're like gardeners. They can't put the plants in the ground. They can just maintain them once they're there. Same thing. Now, osteoclasts are our fourth type of bone cell, but it does not come from that mesenchymal lineage, okay? Osteoclasts are actually white blood cells. So they're coming from a white blood cell line. Now, these are interesting cells. They look like little amoeba, and they secrete hydrochloric acid and lysosomal enzymes. So these have the ability, these molecules, these enzymes have the ability to break substances down. And so what happens is our osteoclasts are reabsorbing or breaking bone down, okay? So they don't break it down in one specific spot and weaken that bone. It's done in a very regulatory way. But our osteoblasts and our osteoclasts are working in opposition to one another all day long, okay? All day long. And we'll talk more about that in just a moment. And that's referred to as calcium homeostasis. Now, when it comes to the gross anatomy of bones, we have two types. So what I'm going to say, let's flip to this slide so I can get a visual. All of our bones, whether it's a skull bone, this is a very generic humerus that's here in this region of the upper limb from shoulder to elbow, which we call the arm. Whether we're talking about ribs, pick a bone, any bone. If it's lying in front of you and you're touching it, the outermost layer of bone that you're touching is compact bone. And compact bone is organized in these little bullseye type structures called osteons. Now, as we move in past this compact bone, we then get into another type of bone, and this is spongy bone. This spongy bone is not organized with osteons, but they're organized with trabeculae. And again, this is right here on this slide, okay? So trabeculae means little beams or also flat plates. It's just the way it's described. Now, if we're talking about flat bones like the skull, like the clavicle, like our os coxae, so our hip bones, or our vertebra, these bones are completely filled with our spongy bone. Long bones, however, only have spongy bone in the ends, okay? We call these ends the epiphyses, okay? Epiphyses. So our proximal, there's that term, and distal epiphyses have spongy bone in them. Any place that I find spongy bone, this is where red bone marrow is located, Okay, so in our flat bones that are filled with spongy bone, red bone marrow. At the ends of my long bones, red bone marrow. My long bones in the middle, this is called the shaft or the diaphysis, they're hollowed out. They just have the compact bone on the outside, like all of our bones do, but on the inside, they have this hollowed out medullary cavity. Here, I have yellow bone marrow, which is fat. Now, going back to what I just said, the very outer layer of bone is going to be compact bone, but that's not the outermost layer of tissue on our bones. The outermost layer of tissue is a membrane called periosteum. Periosteum's job, and it's really, I mean, it is intertwined in those fine little pores of bone, and it's practically impossible to pull the periosteum off of bone. And its job is to be able to anchor tendons. Tendons couldn't get an anchoring point onto bone, but by putting this periosteum on there, those fibers that are making up the tendons and the ligaments can actually penetrate into the periosteum, become incorporated in the periosteum, and hold that tendon in place, okay? And so that's what we've got. And it also helps hold in place vasculature so it doesn't pull away from the bone, okay? So everything I said is right here. So check that out. This is just showing us the osteons. We will have blood vessels and branches of nerve come into our bones and then follow these little central channels and be able to be distributed everywhere throughout the bone. So it's a very highly vascularized tissue. Okay. And this is just showing us the flat bones and how we have the trabeculae. And trabeculae is where we're going to have red bone marrow. Okay. So there are two types of bone formation. The first type is what we call a direct type, and it's the intramembranous ossification. So intra means within, so within a membrane. This happens only one time and one time only. That's at 5 to 6 weeks gestation. Gestation is a fancy word we use for pregnancy. Okay, we can also say development, but at 5 to 6 weeks gestation, we start to see this membrane, right? It's a sheet-like tissue membrane that's made up of stem cells. So these are, it's mesenchyme, right? That's our embryonic tissue. So we have all of these stem cells, all of these mesenchyme tissue in here. And at 5 to 6 weeks gestation, we go from one moment having mesenchyme to the next moment bone cells show up. By bone cells, I mean the osteogenic stem cells. Okay, so we go from mesenchyme right to bone cells. Now, this is the way that, and I'll show you a picture in just a moment. This is the way that we form the bones that make up the skull, including the mandible and also the clavicles. This is how these bones and these bones only initially form through intramembranous ossification. Happens one time and one time only. These genes are upregulated. This growth occurs, and then the minute those bones are formed, those genes are downregulated forever. They don't come back on. Okay. So this is coming from your textbook. This is showing us that here's our mesenchyme. And then one day we have our osteogenic stem cells, and then they turn into osteoblasts. And then as we move those osteoblasts, they form that bone matrix. Do you see how they're getting further away from their neighbors? Once they get far enough away, then they mature into osteocytes, and that bone is maintained. Then the bone becomes modified. Bone then either gets organized as compact bone or spongy bone. And then we have blood vessel and nerve intrusion. And then we get this kind of formation, okay? So this is just a diagnostic, no fetus was harmed. This is just showing a 12-week fetus, and we've got the skull, the mandible, and the clavicle, okay? And this is from your textbook. Now, how does that differ from the other method of bone formation? This is called endochondrial. This is within cartilage. So think of this. We've all seen 3D printers, right? We can take a 3D printer, and essentially engineers do this all the time. They come up with an idea or a concept and go, I wonder if this will work. So they print it out on a 3D printer using a polymer. They take it, they look at it, they move it around. Maybe it's got different parts. They're going to put them together and say, yes, that works. Now we're going to take it to the machine shop and make the same part or parts out of titanium. Okay, once you've got that form that you know is going to work. Now let's apply that here. What we have is a more indirect method of making bone. So with the exception of the skull, mandible, and clavicles, this is how we make all the other bones in the body. It is indirect and it takes longer. We start off with a model that's made of hyaline cartilage. So all of the bones are made of hyaline cartilage first. So these are our templates. And this begins in the 2nd month of embryonic development. And this is also the method that we're going to utilize throughout our adulthood for wound healing. And I'll compare that in just a moment. So we start off with that hyaline cartilage template. Everything looks good. Okay, we don't got any problems. Okay, bring in the bone cells. And now we start to slowly replace cartilage with bone. And that's why it's indirect. So this is everything I've said is right here. I know there's a lot of words on this slide, so I would rather discuss it using this. So we start off with our hyaline cartilage template. So again, everything I'm going to say is going to be on this slide, okay? So here's our bones made of hyaline cartilage. Looks good, looks good. Okay, bring in the bone cells. So we start off with bringing in or replacing cartilage with bone in what we call a primary ossification center. And it starts right here. At the same time, we also have this collar of bone that forms around the outside. So it's like, imagine the bone, if you will, and then this collar that forms, and inside of it is the primary ossification center, okay? So I know it's kind of hard to see, this is a cross section, but that collar goes all the way around. So as the collar grows up, as you see in the second picture, the ossification center, the primary, is going to grow up as well. We get to about the 3rd month of gestation, and this is based on human or primate development, right? So 9 months to birth. And then we start to see, right before birth, a secondary ossification center happening at the epiphyses. We've also got at this point in time a medullary cavity that's hollowed out, and both compact bone and spongy bone that's formed here on the ends of the diaphysis. Okay. Now I want you to notice something. We would think that when we are born, that our bones are more developed, right? It should look like this. Not the case. Look at this. Okay. And if I go back here for just a moment, look at this. We are a species that develops to be able to be delivered vaginally. And that's not a whole lot of space. So we're not a species that has to be delivered and then hit the ground and go, okay? Species like that require their young to be in the first hour of their life and be on their feet for survival are much bigger, okay? They have a less chance of experiencing problems during birth than something like us, okay? We have these big brains, we can create amazing things, but childbirth is, we have evolved to be, you know, that's not a super easy process when compared to other species, other primates, or just other species in the mammalian kingdom. So what we have is we have to have a baby that can essentially fold up and be very squishy. So we don't have joint formation. The joints are there. They're made of hyaline cartilage. They're waiting to be formed. But that process doesn't happen until well after birth. That first year of life, we have no idea. We take it for granted how quickly everything is developing. Organ systems, the skeletal system, the muscles, how quickly your brain is developing, all the things that you're seeing and learning, and speech and memory and muscle memory, functionality, crawling, standing, walk. I mean, it is incredible. That's in 12 months. 12 months. And so then we, when a baby fusses and is, crying, we're like, well, I don't understand why. Imagine what that must feel like. We don't remember what that feels like, right? I'm growing pains, absolutely, because there's nothing like that first year of life and the changes, the physiological and anatomical changes that occur. So just something to point out. Now, when we get into that early childhood, our long bones are not fully formed, okay? Meaning they've got these epiphyseal plates of cartilage that's maintained. So this allows for long bone growth. When I finally reach puberty and I have an increase in the production of sex steroids like androgens, estrogen, and testosterone, that triggers a closing of the epiphyseal plates. It just means that no more cartilage is formed. So when bone takes the place of cartilage, once we have replaced all the cartilage, we have full fusion, and then we're done. We're an adult, or at least by physiological standards. These then we refer to as epiphyseal lines. So that's our two types of ossification. This is for all the other bones in the body, and we modify this for wound healing, or specifically bone healing, excuse me. So this is just comparing the two. Here's our intramembranous. Here is our endochondrial. And this is just showing us what's happening in those epiphyseal plates. If you see an X-ray like this, and you see these epiphyseal plates, you immediately can recognize that this is a prepubescent individual. So I said that this is how we also heal bone. And how is that? Well, because, as we just were reminded, bone is highly vascularized. So any kind of fracture is going to cause a disruption in blood flow. So we have bleeding. The first thing that occurs is a hematoma, which is a big clot. Now that's a good thing, because if there are any little bits and pieces of bone, right, if we unfortunately had something like a comminuted fracture, and I'll show you a picture of that coming up, it's going to help hold all those little pieces together. The next thing is that your immune system is activated, and we have cells that are going to come in and clean up this blood, okay, this clot. At the same time, we're building, look at this, a cartilage template. So this is a callus, a fibrocartilaginous callus, not a hyaline cartilage. We're using fibrocartilage. Fibrocartilage is a lot thicker, okay? And so it's going to hold this bone together. It is bridging the gap. And we put a lot of it in there, right? Do you see how we've got a lot more than what we need? But that's okay. During the time that we're healing then, so say we've got that cast on, we've got immune cells that are coming in, helping clean up any kind of cellular debris. And then we've also got the replacement of cartilage with bone, endochondrial ossification. And then we've got remodeling that occurs because, see, we produce a little bit more than what we need. And then we just kind of go and we take the sandpaper to it. Not really, right? But you understand what I'm saying. We clean it up until the point that we get done and bone remodeling has occurred. Now, this is the very straightforward, right? If we would have to put anything like plates or pins in here, if it was a really nasty fracture, this would just be occurring in addition to, the plates and the pins are helping during this process, okay? They may stay in there, they may not. So what are our types of fractures? Well, here's a comminuted fracture, right? Lots of bits and pieces. Here's a compression fracture. Spiral fracture. This we see only in our prepubescent individuals where we have this separation of the epiphysis. Okay, can happen at the proximal or distal epiphyses. Typically, we're going to see it more so in the proximal, but that's not a rule set in stone. We really have to be cautious of this because when we have this in a prepubescent individual, this traumatic separation could cause the premature closure of our epiphyseal plate. And so we would have part of our bone continue to grow and part of it not. And so that could really complicate growth. And so we would have to move forward on a case-by-case basis. Here's a depressed fracture, typical of skull fractures. Here's a green stick. Children have more inorganic material in their bone than organic. And so when they bend their bones in a very awkward way, they typically don't get complete fractures. They get what's called a green stick fracture, and it's just on the outside in the compact bone. Okay, so there are a couple hormones that are helping regulate bone growth. Of course, growth hormone, right? This is produced by the anterior pituitary, and it's what's helping stimulate in regards to bone, right? We're just looking at bone. It is what is helping stimulate more cartilage coming in and being laid down when it's replaced with bone. So, we grow, bones put in there, more cartilage. Cartilage is replaced by bone, more cartilage. And so that's what's happening. That's being driven by growth hormone. Thyroid hormone ensures that the skeleton is growing proportionally. Then our sex hormones or steroids like estrogen and testosterone, when we go through that pubertal period into the post-pubertal period, when we have enough of a blood concentration of these hormones and they're sustained, either cyclical or in the genetic male, sustained continually, we have a fusion or a closure of those plates, and we call those epiphyseal lines. Now let's go back for a moment and talk briefly about the blood calcium homeostasis. So what I'm going to say that's on here and here, I'm going to sum up here, okay? And then I'm going to go back and just touch on a few bits. So let's say our blood calcium concentration, about 10 mg per 100 mils, is just kind of this, right? It's never set in stone. We know that as we're ingesting, as we're digesting, as we're moving around and being active, all of our homeostatic points are just floating like this. So you've had, say that you like in the morning, you want to get up and you want to have a yogurt and you want to have tea with a lot of milk. So your calcium level then, once that's been absorbed, goes like this. So you have a lot of blood calcium concentration. And we don't like to keep a lot of molecules in our blood, like calcium, like glucose, right? We like to store those things. So our thyroid gland secretes a hormone called calcitonin that regulates calcium. So calcitonin from the thyroid gland stimulates osteoblast activity, and those osteoblasts pull that calcium out of the blood. They put it into the bone, and then our calcium comes back up like this. Now we go through our day. We haven't added a whole lot more calcium in our diet. And now we're at the end of the day and say, we're going to go do something active. Maybe you're going to go for a hike. Maybe you're going to go for a run. Not in Florida. You do that first thing in the morning, right? We're going to say it's wintertime in Florida, winter time in Florida, where it's cooler temperatures. So you're going to go for a run. Your muscle contractions need calcium. Okay, we've got a lot of stored calcium in the muscles, but we also like to bring more calcium in to those skeletal muscles. So now, okay, we're kind of like this. So now we need to be able to stimulate our osteoclast activity, and we do so through the parathyroid glands. Now, P-A-R-A means beside. So these are glands beside the thyroid. Actually, they're on the back of it, okay? So the parathyroid gland secretes parathyroid hormone. Not a whole lot of imagination went into naming this sucker. And the parathyroid hormone stimulates osteoclast activity to break bone down, and it releases calcium into the blood and gets it to the tissues where it needs. So that's what's discussed here and here. Okay. Interesting thing about parathyroid hormone is that it is one of the hormones that can be produced and released during what's called paraneoplastic syndrome. Okay, so certain cancerous tumors can start to produce, synthesize, and secrete hormones that normally the tissue would not, right? Typically, parathyroid hormone is going to be produced from the parathyroid gland. So if we take a blood sample and it comes back and PTH is off the charts, okay? We're going to be looking in the body for a tumor, cancerous tumor, that is able to secrete this hormone. Now, we can see this with other hormones, but we do see it rather commonly with PTH. Now, you can imagine your body, the bones in your body, they don't recognize that this PTH is being made from a cancerous tumor that shouldn't be, and not the parathyroid gland. So what does parathyroid hormone do? It stimulates osteoclast activity, breaks bone down. Now we're going to have a patient who also, in addition to having a lot of PTH in the blood, is also going to have very weakened porous bones. And they're also going to have a very high blood calcium concentration. So just something to think about when, maybe you're going to be in the clinic, maybe you work in a diagnostics lab, and when you see those data come back, or you hear, your doctors that you're shadowing or your nurses, and you hear them read that patient's chart, be looking for things like this and make those good connections. Okay. So that's blood calcium homeostasis. So some disorders that we can have with bones then, we said bone cancer. So that's going to be an osteosarcoma. We can have a deficiency, a calcium deficiency, or a vitamin D deficiency. Now, if you look around your kitchen, our bread is fortified with vitamin D and calcium. Our dairy products are fortified with vitamin D, okay? Our cereals are fortified with vitamin D. Why is that? We need vitamin D in order to help absorb calcium. So if we have a vitamin D deficiency and or calcium deficiency, it can lead to this mineral deficiency called rickets. Now, it's rickets in children, osteomalacia in adults. Why do we need two names? I have no idea. I'm guessing that they first found it in children and somebody named it this. Then they saw somebody else, saw this in adults and they gave it a more adult type name, right? Osteomalacia. And then they said, well, hey, this looks like rickets in children. And it's the same thing. And rather than call it the same thing, they just kept the name separate. Okay. So that's what we've got. And then last, but certainly not least, osteoporosis. So this is when we have our osteoclast activity outpacing osteoblast activity. So this results in low bone mass, or we say a decrease in bone density. Okay, so our reabsorption outpaces our bone deposition. This occurs in women after menopause because when we have a decrease in estrogen in the body, estrogen is very important for helping maintain bone density. It helps facilitate calcium absorption. So when that is compromised, the osteoclast activity, it hasn't sped up at all, okay? It's just that bone deposition, we're not as proficient with that. And so the osteoclast activity outpaces osteoblast activity, and we get osteoporosis. And this makes our bones weak, and then it makes us predisposed for fractures. And we'll talk more about that throughout the different blocks. So for this part one of this introduction to anatomy lecture, so there's two parts to this. The last thing I want to talk about in this first part is joints. So joints or articulations is where we have two bones coming together. So there are several types, and we're just going to touch on briefly touch on them. So the first type is a fibrous joint, and these are going to have fibrous connective tissue that's in between the two bones that's meeting. There's no joint cavity, and these are immovable to just slightly movable. These are going to be in the sutures of the skull. So what we're going to see in block 2 is that when we're born, our skull bones are not block 2 in the head and neck lecture, pardon me, is that our skull bones are not fused when we're born. They're actually separated by connective tissue, and these are called soft spots or fontanelles. Again, I need this skull to be malleable when I'm coming through the birthing canal. And so in the first 2 years of life is when the skull bones actually fuse. And when they do, they form these immovable joints that are called sutures. Syndesmosis joints that are held together with ligaments. And we'll talk all about this in block 5. And this is where we have our fibulotibial ligaments that are helping then form those articulation points, both proximal and distal. Our gomphosis joints, okay. We do have this periodontal ligament. If you have ever had a tooth removed, if you've ever seen somebody have a tooth removed, you know that it feels like they're removing your entire half of your face, taking the tooth off and then putting your face back together. This is a very tight joint, okay. It takes a lot of force in breaking that ligament to get that tooth out. Now we move into cartilaginous joints. Okay, so again, these were fibrous joints. These are cartilaginous joints. So we can have joints, again, they lack a cavity, but they're filled with hyaline cartilage. So for example, our epiphyseal plates. We're going to learn about this in block 2. Our ribs don't have a direct connection to our sternum. Instead, they have this hyaline cartilage piece that's helping indirectly join them together. Then we can use a thicker type of cartilage, a fibrocartilage. This is what we know the outer layer of our intervertebral discs are made of. So we're going to learn in block 2 in the back. We have these fibrocartilaginous discs, but it's just the very outer part of these discs that are fibrocartilaginous. They're not completely fibrocartilage. On the inside is a gel-like center, but it helps with compression. It helps with movement, and then also eliminates friction of bone-on-bone interaction. The pubic symphysis. This is my left and right os coxae that's helping form the pelvic girdle, and anteriorly, they are articulating with one another at that pubic symphysis. And last but certainly not least is the most diverse and also probably the most abundant joint type in the body, and that's synovial joints. So these are, they have a fluid-filled joint cavity. So all of these, there may be some modifications, but all of these are going to have a very thick ligament on the very outside. If I was to remove the ligament, then I have a 2-layered synovial membrane. I have the outer fibrous layer that I refer to as the joint or articular capsule. And then if I stripped that fibrous layer away, I would see this synovial membrane. Now, this membrane has a lot of vasculature in it, okay? Now, we have fluid found throughout our bodies, right? Lymph fluid, cerebral spinal fluid, synovial fluid. Where's it coming from? The blood. This is just blood plasma, okay? Our blood is made up of a fluid component called blood plasma, and then there are all the formed elements, the cells, the proteins, carbohydrates, glycoproteins, all the other stuff that's in there, dissolved. Water is the universal solvent. We learned that in biology. We learned that in Chem 101. And so everything else is dissolved in water, whether it's just floating in there or really dissolved in it, right? Where the chemical composition changes. And then when we're ready to remove it, we precipitate it out, okay? Throughout the body, we precipitate elements out in capillary beds. And this is the second part of this introduction. We'll review that. Blood comes into the capillary. There is a push pressure. Blood plasma gets pushed out along with certain things that are dissolved in it, glucose, gases. We have exchange at the cellular level. And then on the other side of the capillary bed, that blood plasma is pulled back in, and it brings back with it metabolic waste. This water, this fluid component that is blood plasma, it's just a vector, right? How else am I going to move things from point A to point B? How else am I going to get nutrients out of the blood to the cells, pick up metabolic waste, and get that back into the blood, right? It's like a little mailman or mail person. It delivers, it picks things up, brings it back to the mail truck. That's all it does. And so it's blood plasma, but I can't call it blood plasma here. I have to be specific, right? Blood plasma could be, to me, that's inside the blood vessels. Here, I say, well, I have filtered this out, which is what I do. I filter it, I pull it out in these specialized tissues called membranes, right? I pull it out, or a type of membrane. I filter it out, and once I get it into this joint capsule, it is synovial joint fluid. Just like anything else, when I pull the fluid out, I need to recycle it back into the blood, and I do that as well. So it's just a constant production and recycling. So what we're going to notice is, if you've seen blood plasma, it looks like egg whites. It's very slippery, those glycoproteins, and it makes it a little slippery, sticky, but slippery. And that's a good thing. It helps decrease the friction, actually helps almost eliminate the friction in these joint cavities. My bones that are within this closed synovial joint, at the ends are lined with hyaline cartilage. And this hyaline cartilage is kind of thick, and it acts like a little sponge. So it actually soaks up that synovial joint fluid. So if I do have any bone-on-bone interaction, or really hyaline cartilage on hyaline cartilage interaction, and they squeeze down, the hyaline cartilage takes that compression and it squeezes out that fluid, and then it soaks it back up again. So it's very interesting, very unique. That's what we've got in here. Now, these synovial joints, we can classify regarding shape, okay? And we are going to see a lot more variety in the upper limb and the lower limb, okay? So for example, we classified them by shape and then by their movements. In the wrist, in the carpals, we have these gliding movements, and we're going to talk about that in block 4. This is just introducing them. We've got hinge joints. The best hinge joint that I can give to you is the ulna, the proximal C-shaped end of, not the head, the end of the ulna on the distal end of the humerus to form the elbow. Pivot joint. We have this between C1 and C2, which is our first 2 vertebrae of the vertebral column, that allows me to do this. Okay, it's a pivot point. But also, there is a second bone in the forearm that's on the thumb side, so the lateral side, that has a wheel-shaped head. So the wheel-shaped head of the radius allows me to do this, acts as a pivot point. And we'll talk more about that in block 4. ellipsoid joints. So these are my carpals, these are my metacarpals, and so where my metacarpals and my phalanges meet up, we've got these ellipsoid joints in here. And so it helps with biaxial movement. Saddle joint, right here she be. Digit number 1, the thumb. Helps with opposition. Ball and socket. This is really easy. We've got this in the hip, and we've got this in the shoulder, for examples. Multi-axial, lots of movements. Okay. And what are some joint pathologies? Well, probably most common, right, that you're going to see clinically is arthritis. Now, this is an umbrella term, okay? It just means that we have an inflammation in the joint. But how we get there, how we can get arthritis, well, that can be a variety of ways. Rheumatoid arthritis is an autoimmune disease. With all autoimmune diseases, your body no longer recognizes self as self, okay? So the body starts to attack the cartilage and the synovial membrane, to the hyaline cartilage at the ends of the bones, and the synovial membranes starts to break them down. This causes inflammation, swelling, pain. And so it can actually destroy the cartilage and cause bone-on-bone interaction, and we can actually have joint ossification, so joint fusion. Now, that's different from osteoarthritis, and this is the majority of what you'll see clinically. This is just a consequence of age. You're just wearing your body out, right? It's degenerative joint disease. It's associated with aging, okay, deterioration of that articular cartilage, or, degeneration is specifically with the articular cartilage. No problem with the synovial membrane, but as the cartilage breaks down again, you get more bone-on-bone interactions. And last but certainly not least, gouty arthritis. This is a metabolic disease. So once known as the King's disease, because we typically saw it in typically white, middle-aged, or what was middle-aged back in the times of the kings, men who had a very high diet of meat and very fine whiskey. And so what can happen with that high protein diet and sprinkling a little alcohol in there, you can produce too much uric acid, and that gets then excreted into these joint cavities. And so these crystals, they show up as uric acid salt crystals, will get into the joint, and it will grind in that synovial fluid when I'm moving about, and it causes pain, a decrease in motion, and it can actually wear away the cartilage and cause fusion in there. And so it's interesting because this can happen to any joints, but we really see it in the joints of the feet, specifically in the joint, the first joint, what we consider the first joint of the big toe, right? In that metatarsal phalangeal joint. So just to give you some ideas. So that's it for part 1. When we come back in part 2, we're going to pick it up with blood vessels. We're going to do a review of that. We're going to talk more about muscle in general, and then also a review of neurons and neuroglial cells. We're going to put it together of how neurons talk to muscles and tell them to move at the neuromuscular junction. And that should be a great review to get us all set up to start our properly first lecture, and that's going to be on the head and neck. So with that, I will see you next time.